Hi, I'm Jim Hoover and welcome to the presentation, Overlay Records, Problem Solved. This is a brand new area of research on a topic that's barely been discussed in our industry. So please enjoy and be sure to send any questions you have to me. I'm more than happy to go into this in more detail. Professionally, I focus on data quality issues in healthcare systems. I have a master's degree in computer science from Johns Hopkins University, and I've been in the healthcare information management field for about 10 years. I'm the founder of Avant Sciences and chief scientist, and I also am the lead informatics instructor for Health Informatics Masters and Healthcare Administration at Charter Oak State College in Connecticut. So I'm kind of nerdy. The standard disclaimers apply. I'm presenting this information with the best intentions to educate the audience. Healthcare data problems are real and can have profound consequences if they're not solved correctly. So please use your best discretion in applying this information to your specific problems. So before we begin, let's make sure we're on the same page when it comes to definitions about data. Patient data can contain any of the following information: demographics, measurements, medical history, scan documents, clinical notes, financials, claims data, etc. And in fact, patient records can contain other data types, such as SOGI or SDOH information as well. Duplicate records are defined as a single patient with two or more medical records in the same master patient index or electronic healthcare record system. One database, two or more records. And by the way, there's probably a much better term than duplicates to describe this phenomena, because duplicates imply an exact copy, whereas these medical records are really partial records, not copies. And so therefore a better term to describe duplicates would be partial medical record. To add more fuel to the fire, duplicates also imply two records, whereas many patients have 3, 4, 5, 6. I've even seen patients with as many as 13 records for the same patient. If you have an interest in this particular topic, please follow the QR code on the screen to read my blog post on why we should change the name of duplicates to partial records. Overlay records are a single patient record with information from two or more patients inside it. I suggest we also change the term of overlays to something that is more meaningful and used more in research, and that's called wrong patient errors, or WPE. But during this conversation, we'll use these terms interchangeably. When I first got into healthcare a decade ago, I wrote an algorithm for patient matching based on some work I did at the National Security Agency in the 1990s. Patient matching looks for similarity between records, and I had algorithms that did precisely that. But then I had a realization. What if we used the same algorithm? Instead of looking for similarity between records, we looked for dissimilarity. That is, things that do not belong. And instead of focusing on records that should be matched, let's focus on encounter data that maybe does not match the rest of the encounter data. And that set me on the path of solving the overlay data record problem. Everyone has talked about duplicates so much at conferences and in articles, but we are all quoting the same information. There's not a lot of new research there. We're all talking about the same 8 to 12% on average duplicate rates, presenting the same information at presentation after presentation at EHRs and the state shows. And every vendor in the space offers the same service with the same algorithms, more or less. But many of those algorithms are from the 1950s, 70 years old. What was most striking to me, though, was how little everyone said about overlays. It was just crickets. And that brings me to the purpose of the discussion today, overlay records. Why do we not have much information about them? From my understanding, there are several reasons. Firstly, very little original research has been conducted on the topic. We've studied duplicates for many years, but virtually nothing on overlays. Overlay data can occur any place in the medical record, so we have to look beyond the demographics to find the information. Clinical data, financial data, and demographics. And they're very hard to detect. This requires us to have new approaches and a combination of deep domain knowledge in linguistics, artificial intelligence, statistics, mathematics, patient records, CDI, even billing. All of these things are required to solve overlay data. Why is this important? Well, the patient risk is incredibly high. They can have incorrect allergy lists. Patients can have canceled appointments, such as when one patient was incorrectly marked as deceased. And when the very much alive patient showed up for her appointment, she learned all of her appointments were canceled.
What?
Because she was marked as deceased. Crazy. There have been in vitro fertilization mix-ups that have caused the wrong babies to be born to the wrong patients. Patients are not even safe in death from patient mix-ups. There's been organs harvested from the wrong patient. Patients have the wrong blood types. Sometimes they're exposed to additional x-rays or other procedures that aren't necessary because their information's lost, it's in another record. That also happens with duplicate records. From the provider side, there's unreimbursed expenses because of repeated labs or other procedures. And something we rarely discuss is the risk of compliance violations. Both HIPAA and the 21st Century Cures Act have substantial penalties for these data errors when they're exposed to the patients. The Emergency Care Research Institute, ECRI, has created a taxonomy to classify the impact of data errors on patients. And the impact ranges from possible harm to the patient, but they're not aware, to the patient knows of the error and the error has caused temporary harm. And at the extreme end of the spectrum is when the harm is permanent or even death. But we can use this taxonomy to gauge how impactful these data errors we're solving are. And we see that a lot in medical informatics research. Overlay data has the potential to do permanent harm and death. So this is a useful taxonomy for us to consider as we look at data errors. The current state of quantifying overlay records is weak. They're dangerously undercounted, and there is no common industry approach to solving this problem, or counting, or cataloging the types of errors. We do not systemically measure any sort of overlay data. We do a lot with duplicates, but we do very little with overlays. Publications often mention duplicates and overlays in the same context, but then they present the solution only for duplicates. It's kind of comical. You'll probably see it now that I mentioned it. What the goal of this presentation is to present the first comprehensive solution to overlays, so we can really start to fix this problem. There has been some work on measuring near misses. Physicians have been known to issue an order for the wrong patient, notice it, then retract that order, and reissue the same order for the correct patient. Thus, a RAR order measurement has been built into EHRs after researchers found this useful. Sounds like a little lion, RAR. A 2019 study found that approximately 0.1% orders were RARs. It's a small percentage. The burning question is, how many orders were missed? That is, were not identified to physicians to be incorrect. How many went unnoticed? In other words, we do not know what we do not know. The current state of detect and overlay records is abysmal. Certain EHRs, such as Epic, have recently started to create a queue of changes to demographic data and calling that overlay detection. But what this is doing is it's overburdening the HIM departments to look at every single demographic change and see if it has any meaningful value when it comes to overlay records. But that's it. This space was intentionally left blank in the slide because there's no other solutions out there. We're still waiting. And that's what we're going to talk about today. What we need is true detection, and that requires an analysis of clinical and financial data, in addition to demographics. We need early warning systems to detect these overlay records in real time or near real time. And similar to data deduplication, patient matching, we also need to bulk clean our EHRs to find historical overlay data in the wrong record. I've collected dozens of anecdotes about overlay data in the real world, and one was particularly interesting where a Navy corpsman was missing information for his Purple Heart. Turned out it was in another retired serviceman's record that was an overlay. So these missing data elements have impact for both patients, the one who has extra information and the one who is missing it as well. And there's real cost to the institutions for overlay data too. The cost of undoing a record that has been merged has been discussed a little bit, but not often. It's kind of hard to find the research. But there was one case that I recall reading where there were twin sisters that it took 16 staff members 3 months to separate the records. That's a big expense for just 2 patients. In addition to that, you're not able to reimburse for the missing services for the patient that actually received them, usually because you discovered it too late. There are many causes to overlay records, and it's important to understand that there are more pathways to overlay data errors than for duplicate records. Many errors on both sides, however, start from patient search failures in EHR. That's the root cause of most problems. There's also interruption errors when clinicians are distracted typing their notes into a clinical chart, and they turn away, talk to a colleague, come back to enter notes, but in the wrong window. In a similar way, clinicians also have or can have multiple windows open for different patients at the same time. Copying, pasting from an encounter to another encounter often can mean copying the data to the wrong medical record, for example. Lab results can be reported incorrectly, and of course, patients can be misidentified, as we know all too well from our study of duplicates. And lastly, in our world of health information management, when we do data deduplication, records can be incorrectly merged for 2 patients that look similar. This happens a lot with twins, but can also happen with spouses, family members, or people with the same names. And if we dive down on incorrect merge records a little bit more, there can be some concern about auto-linked records where the thresholds are too low and records are merged without a human involved. So that's something we have to watch out for. Sometimes contractors will use undertrained labor for low cost to do the actual merging of the records. And something else I've seen in the past as well is sometimes there is just not a good quality assurance process for merged records. This happens a lot of times when there's limited staff on doing data quality. But another problem I've seen quite a bit are non-existent, underused, or under-maintained known non-duplicate list. This is more of a technology problem than it is a people problem. The core issue that I see are that EHR searches are not very sophisticated. They use technology from the 1970s and 80s that requires exact text matching, and I'll use the NPESS MPI search tool as an example to illustrate the principle, where just missing simple characters, an A for an I or something like that, or a missing dash will cause the search to fail. Transposing characters, for example. Epic's more recent update has a better search where you can have 2 or 3 errors of a limited type of errors, and it'll still function up until a point, but then it fails as well pretty quickly as the error rates grow. Very few search systems work well with first name, homophones, or alternative spellings. Soundex is a common solution that's used in Cerner and other older tools, but only works for American English pronunciations, and it's very old. It was patented in 1919. Patient misidentification is one of the most preventable errors that we have. My first name, for example, is very common for men in America, same as my last name. A simple search on the MPI database, LinkedIn, Google, or any other source will find hundreds of James Hoovers. And the bigger our EHRs are, the more challenged this becomes. So searching by name is never a good idea. Multiple birth siblings, as we all know, are a really difficult problem to solve for patient matching. This is a frequent source of overlay data issues as well. Ask any parent that has twins or triplets, and you will hear countless examples of how their records got messed up for the children. And it's a hard problem to sort out, especially when siblings have similar names, maybe off by a letter or two, when parents want to name the children in a rhyming sort of manner. It's cute, but it makes our lives difficult. And then, of course, there are people that share the same name, and they're confused with other patients often. A crazy recent case where two minor league baseball players had the same exact name, looked exactly the same, in the same sport, at the same level, and even had the same injuries and the same surgery to repair it. This crazy coincidence was only discovered when the two were confused on news reports about the sports injuries. And then there are generational names. Even women sometimes have junior in their names. It's not common, but it happens. And also the last name for certain cultures is inherited from the father's first name. Certain Middle Eastern cultures, Russia, Iceland, for example, a male with the name Anderson is the son of the man called Ander. So there's lots of Andersons and similar names out there in Iceland. Of interest, about 23 of Americans go by nicknames. My name is Jim, which is a common nickname from James. And I was also called Little Jimmy when I was a kid, a diminutive form, which is common in other languages such as Spanish with Javi for Javier. And all of these impact patient identification. Many don't think about is how we search for patients to begin with, which is often by date of birth. But date of births are not unique. Consider the birthday problem. There's a 50% chance that two random people in a group of 23 will share the same birthday. So we have to be really cautious looking up people by the dates of birth and last name only because they're not unique and both are error prone. Dates of birth are likely to have errors as any other field in the healthcare database. There are better alternatives for search, like telephone numbers and emails that are more unique. Another way clinical data is input into the wrong record is through copy and paste. Copy and paste has been subject to debate for a long time. It's about productivity versus data protection. But this is a common action that physicians and other clinicians do, and so we have to be aware. One study attributes 36 of medical record errors due to copy and paste, so it's an obvious challenge. Further, copy and paste creates note bloat, which obscures relevant clinical data, and it makes it harder for physicians to read the patient records. Now let's move to talking about what we do know about the metrics for wrong patient errors or overlays. Indeed, there's only a handful of studies that have been published that help us understand the level or depth of overlay data / wrong patient errors in the healthcare systems. One study evaluated the risk for the data and determined that people with similar surnames or the same surnames were present in 34 patient days, or just under 10% of all the time patients were in the hospital. This was especially true for babies in the NICU unit, which faced substantially more risk because they also had similar first names, baby boy, baby girl. A patient day is defined by the number of patients in a hospital per day. For example, if there's 20 patients in a small hospital in one day, that's 20 patient days. There was not a single risk-free day for patient misidentification because of these errors in a NICU study that showed there were 17 patients at risk each day, which is over 50% of their average daily census. And because of this at risk for misidentification, 25% of the patients received incorrect medications or medication levels. And also 25% had feeding errors because they got the wrong expressed breast milk from the wrong mother. because of misidentification. A journal of the American Medical Association published a study on patient-reported data errors. This self-selecting group for the study was about patients who accessed data on the portal and how many of those reported data errors. Of the many ambulatory patients that responded to the survey, 21% had actually checked their records and reported errors. And 85% of those reported errors were classified by the patients as serious or somewhat serious. But interestingly, only 0.1% of the records checked had data from other patients in it, overlays. And we're going to call this the low watermark for wrong patient errors, 0.1%. It's measured by a real study, so we know it exists. So from these two very different studies, we have a very big range about the scope of the problem, from 0.1% to 25%. That helps us bound the data error rate. And there are other studies, of course. My thesis is fairly simple. That is, overlay and duplicate data errors probably have the same rates, or similar. Both can originate during patient search. Duplicate patient records occur when a patient can't be found, so a new record is created. Overlay records happen when the wrong patient is found and data is entered into that record. Patient search is a common root problem. Overlay/wrong patient errors have more error pathways. Thus, we have to look harder for different causes and different solutions, different methods of prevention. That NICU study we mentioned, where the patients faced 21 to 75% risk of being misidentified every day, is a cautionary tale to us, meaning the problem is very big, much bigger than I think most of us realized. The MRNs are also similar, not just the names, the last names and first names, but also the medical record numbers, off by one or a small number of digits because of how MRNs are assigned in a sequential nature. That's how we often can determine if two patients are multiple birth siblings or not, if the MRNs are close. Personally, I've measured duplicate rates as high as 23.5% and as low as 2%. All of us have seen this 8 to 12% average duplicate rates as discussed in many PHIMA publications. All those numbers should be refreshed because they are as old as at least 2016 from the first reference I've seen to them. The best data we have on overlays have been measured by those two examples, 0.1% to 25%. My suspicions are the averages are much narrower, so I believe through more study we will find the ability to more closely quantify what the typical risk is. A study I did for a public health data set, for example, found the variance in height and weight data only to be about 3% for their data set. So there was 3% of the patient population that were at risk for possibly having overlay data in their records. What we really need in industry, what I personally need as well, are research partners to better quantify range of overlay data. With more knowledge and awareness, more providers participate in studies, we can start to address the issue, hone our solutions, and publish it so everyone in industry is more aware of the extent and dangers of the problem. Now that we're all convinced that wrong patient errors, overlay data exist for real, we can start to discuss how to detect them and solve them. Overlay prevention is at least as important as duplicate error prevention, and the processes and solutions run a parallel path. Common search protocols today actively encourage overlays. Common search protocols actively encourage overlays. Meaning we encourage people to type less rather than more, because if we type too much, these systems don't match. But in general, a better search solution would be allowing those looking for records to type as much information as they have. fully specify the patient and let the system figure out from its algorithms and capabilities which records best match what was typed, rather than the user trying to game the search to type very little and select from 10 pages of James Hoover's, for example. Older search just fails when we put too much information in. This does require a change in philosophy, meaning search technology is old and we probably need a Google-like functionality to work better, seamlessly. And they exist, we just have to adopt them. Now let's move on to the point of the presentation, the solution. What is the foundational science for wrong patient errors / overlay records? The wrong patient error overlay solution pathway means the solution set must deal with all of the patient data, wherever we can detect or get tip-offs for overlay errors. This remainder of the presentation, we're going to discuss techniques for each data error type, but this is by no means comprehensive. This is just one research scientist's thoughts behind how to do this. For demographic changes, we can monitor the changes when they occur in real time and then use algorithms to determine if something rises to the level of a possible overlay. Not just put everything into a queue and call them overlays, and then have individuals on the data integrity or HIM teams look to validate. The software should do that. We also need to look at the measurements made from the patients, the vitals and clinical data, and this requires the use of statistics, mathematics, artificial intelligence, natural language processing, as well as a knowledge of physiology to see if an overlay has occurred. We can also analyze the clinical notes for inconsistencies, and we'll discuss two approaches there, one that requires medical knowledge, one that requires math. And finally, we'll briefly discuss looking at the denial codes that come back from claims that might tip us off to the possibility of an overlay encounter. It's important to notice, though, that we're at the very beginning of solving this problem. But we need to lay down this foundational science for wrong patient errors. And in order to do that, we have to truly recognize that this is a harder problem to solve than duplicate detection and remediation. That's why no one solved it yet. Looking at the big picture, the data is kind of like an onion, many layers to it. And each data type requires different techniques. Demographic data, vitals, clinicals, and financials all have different dimensionality that we have to study and then solve. So let's discuss some specific solution details about monitoring demographic data changes to discover overlay detection in real time or near real time. Demographic data changes might trigger a deeper analysis of overlay happening, but it depends on which fields change. For example, last name changes are quite common, whereas social security number changes from one number to another uncommon. Fields that rarely change or never change should trigger automatic human intervention. And unlike what Epic's doing, we don't need to review every demographic update. We only need to look at those that are suspect. Updating a work address or guarantor information should not involve HIM to see if there's been a data error. One thing I strongly recommend is that we retain changed or replaced data for future analysis. And if your EHR does not maintain this historical information, then we should consider using third-party tools that can keep track of the data changes via simple HL7 messages, just like real-time data deduplication systems do, or downstream systems. Of note is data provenance is key here. Who changed the data, when did they change it, and why did they change it? That's important for helping us to uncover the reasons for potential overlay mistakes. The historical data is extremely valuable in patient matching. If we can augment patient matching with historical data, then we should do that. And by the way, every time we update a record, we should probably match that record or rematch that record against all of our data in our EHR again, so we can see if it now matches records that were not matched in the past. A best practice to help facilitate this is to maintain a list of suspected matches at least, ones that did not have enough information prior to conclusively match, and every time one of those records are updated, then we check at least to see if those records can be ruled in or ruled out as the same patient. But by understanding the flow and the life cycle of demographic data, we can make a model of expected changes and give alerts when unexpected things happen. It matters what changes. Blanks go into new values should be of no alert, but changing a value should take us to the model so we can follow it. Addresses that we talked about, last names, and clinical data like weight changing, probably not a big deal. And some data should cause red alerts when they change. Blood types or height that's way outside of the variance. Dates of birth or social security numbers, for example, if they change from a non-blank value to another non-blank value, then we should maybe consider what's the reason for that change. Did we just update a record with the wrong patient information? I'll quickly step through how historical data and tracking can be used in such a system. I'm just using this mock-up to track the changes over time, and this is all demo data, there's no PHI here. But if we review the changes of the medical data over the life cycle, the first date of birth change might trigger review, maybe there's a new scan of a new legal ID. The second update, in the sense the formal name was changed from a nickname, might indicate that it was a child record before, now it's an adult record later. My record's going from Jimmy to Jim to James is a good example of that. Third update looks like it was a name change to add a compound name. Maybe that's an update on the hospital's policies to finally record both names or to allow dashes in the names. The fourth change looks like a spelling fix. No alert needed there. But maybe by the time we get to the fifth change, where the last name was changed and moved to a maiden name, but the last name then was left blank, looks like a data entry problem. We should look into that. And finally, what about the next set of changes? We got a change to the medical record very close to the last change. And it says patient requested to change, but why? Do we have any documents to back up these significant number of changes? This is the kind of example that could be an overlay. And I've seen this happen in real time at the Veterans Administration. This exact scenario to about 500 records, which turned out to be a software error. So it's very good to monitor these things to detect them. Data provenance is key to understanding who, why, and when, but the what changes is something that algorithms can handle. Don't leave it to the users. Let the software tell you when we should trigger an alert. And those old values of the data are useful for unwinding changes, so that's good for us to have. It's the foundation for undoing record merges that were done incorrectly. Understanding the variations on patient measurements is a very practical and easy solution to understand and implement. But how do we measure those variants? And can we use that information for real-time alerts as well? There are many patient measurements, and we can track and measure the variances from encounter to encounter. For example, we can visually inspect this time series of height versus weight to see if there's any anomalous measurements, as I did for this health department client. And if you notice, there's a strong variation in the encounter in July 2020. This could be due to one of four reasons: a faulty measurement. Maybe it was patient-reported data, because we always lie about our height and weight. The airlines and dating sites both know this all too well. The mistyping of data also happens. You measure it, but you type it wrong. Your finger slips. Or, this is what we're looking for, it could be an indicator that an overlay does happen in real time, or has happened in the past, if we're looking at it in bulk. EHRs do not give these alerts yet, but maybe just like the RAR, redact and reorder measurements that EHRs have implemented, they can implement these as well. But now you can use third-party tools to monitor and report. These third-party systems or your IT department can run these things as background processes to validate every single measurement that goes into the EHR. And then alerts can be generated based when these measurements, the differences exceed the variances and the tolerances that we configure for each type of measurement. Healthy weight gains, for example, between every encounter, say within 30 days or 60 days, can be assumed. And blood pressures can also vary, but if we have one that's way out of bounds for other readings, that might be a cause for concern. And we do have to take great care in preventing false positive. We don't want to have alert fatigue like doctors have with clinical systems, perhaps. Too many warnings cause us to ignore the warnings to begin with. For example, height can vary in a person. You're taller in the morning than you are in the afternoon due to spinal compression. That can be up to 1 or 2 inches variance. Measurements in height can also vary because the posture you have is different. The shoes you have on are different. You might not even have shoes on. Can the person even see the measurement if they're not as tall as you? Blood pressure is a good example as well. It peaks during midday, so we need to take that in consideration. But one thing's for sure, the blood type should never change. We need to alert on that as soon as we detect lab results that have different blood than what other lab results have given us. Also the metabolic panels, the glucose, the creatine, the calciums, potassiums, sodiums, chlorides, bicarbonates, etc. all have different levels that can be tracked, determined if anything's anomalous with prior measurements. Complete blood counts can also be analyzed, each element inside of it, to look for variations. This is all possible with today's technology, but we don't do it. Looking for clinical inconsistencies is where the real science, the new science, comes in. Unless you count statistics as a science, then, well, and the last examples count too. Let's talk about 2 complementary approaches to analyzing clinical data. Remember before I said there's not just one way to do these things, there's many. I'm going to give you 2 for clinical data. The first is a semantical approach, understanding the meaning of the clinical data, and the second is more a data pattern-based approach, which is the organization of the data within the clinical notes, the sequence of characters. This quote is from a research paper I read where the clinician was discovering in real time that the patient had been given food when the patient was supposed to be fed intravenously. Patients have died from this very error. And I've had students with children that have issues that require them to be tube fed, and she has caught the wrong medicine modalities delivered to her child. Could be fatal errors from choking. But understanding the meaning of the data in the notes is important. An elementary start to this is the process to ensure that gender-specific procedures are considered. But in order to do that, we need to know the birth gender of the patient and the specific procedure that was performed. Certain medical procedures are indeed birth gender specific. And for the gender assigned at birth, we must be cognizant that certain procedures might not be appropriate. Also, we have to be aware that there are some intersex patients, so there's no exact answer always, but there are exceptions. The clinical language, the CPT codes that can be verified against the gender assigned at birth, mostly around genitalia, urinary tract, pregnancy, etc., are different for men and women. And this is a clear-cut example where understanding clinical data can help us root out incorrect information in patient records. We can also do summaries of clinical notes to illustrate potential inconsistencies in patient health states. We use natural language processing, NLP, to create understanding of the notes. We use NLP in a lot of clinical data improvement, CDI work, and sometimes for billing. But understanding the summary of the encounters helps us to determine, say, if an active duty military service member is confused with retired military members. I have exact examples of these anecdotes. Or pregnancy outside the expected age bands. Sports injuries for morbidly obese patients, for example, might indicate an incorrect encounter. Might not, but it could. Or the first mention of a chronic condition such as diabetes, cancer, depression, arthritis, etc., that seems to be more of a checkup rather than a first diagnosis is of importance for discovering overlay data. We can also take a different and complementary approach to finding the clinical encounters with errant data. To do this, let's take a slight detour and consider EHR searches and how they require exact matches to find patients. We talked about that earlier. It's a fact that exact text searching is old, and you need to look no further than Google how easy that is to use versus your EHR or other web-based searches. When you know the mistakes in EHR search will not find the patient, whereas a similar mistake in searching for something on Google will still find what you're looking for. That these two things are inconsistent is troublesome, because we could have that technology in healthcare if we really wanted it. And duplicates and overlays are created because of this fallacy of the search tool. But we can use a technique looking at tiny snippets of text for search, and by looking at those tiny snippets of text, as we scan through the text, we can build up a profile of that patient information and ultimately find the data we're looking for. This gets a little bit technical, so I'm not going to get into the math, but it's similar to AI. But those snippets of text, when analyzed and compared against other data, can find information that's similar. That's how we do modern search. I have a whole hour discussion on that topic, so we can't get into that today. But the key takeaway is that it works much better than text-based search. And to illustrate this as an example how fault-tolerant text snippet type of search is versus exact text search works, or matching, we can look at this example of finding a patient name that is severely mangled, but there's enough patterns in the mangled text to still single out the correct patient record, because we're looking for patterns that are similar. But here's where the inspiration comes in. I've been working with this technique for over 20 years. I worked with the scientist who invented it, and I've been using it in healthcare for 10 years. But I had an epiphany. Instead of looking for similar data, why don't we look for dissimilar data? Data that's not the same. We can use the same algorithm to find all the encounters that belong to a patient, and then we can look for the ones that don't belong through the same technique, just using the inverse. That's how we find errant clinical data. And this kind of reminded me of the educational song from the 1970s when I was a child on Sesame Street. One of these things is not like the other. I'm not going to sing it, but
things is not like the other. One of these things just doesn't belong. Can you guess which thing is not like the other before I finish this song?
Anyway, that's the principle, though, of automatically finding clinical encounters. Let's find the one thing that does not belong. And this takes us to how we use that principle for overlay data. Using a pattern matching algorithm, any algorithm that's similar, let's find encounter data that doesn't belong. On a patient-by-patient basis, let's analyze the encounters within that patient record and find the outlier encounters that don't look like the others. We can do this in an automated fashion, so we can analyze millions or hundreds of millions of records looking for historical overlay clinical data. The encounters, when clustered, will group each healthcare episode together because the clinical notes will be similar when describing a broken arm, say, than different from diabetes or other ailments that may be in other episodes. Let me give you one more detail. Data clustering is an important concept mathematically to finding dissimilar encounters. It's also important for finding patients that have more than one duplicate record as well, but very few vendors or organizations use data clustering, but is critical for analysis such as deduplication as well as finding encounters that don't belong. We then calculate what's called the center or the centroid of the cluster and do an analysis to see which clusters are far away from the others. And that's the data we investigate in terms of suspected overlay data. Another thing we can do is analyze the clusters by time. When did these episodes occur? And we put them into a time series that further supports the notion as to whether an encounter belongs to the patient or not. And finally, I'll talk about claims data analysis as it applies to overlay detection or triggers. The financial record itself won't prove an overlay exists, but it could give us an indication of a potential overlay that we have to look at the clinical data for more information. The reason codes for denials might be what tips us off, say like the dates of service are before the birth of the patient or after the death, or duplicate services, perhaps this patient are to receive the same order that was given for another patient. Patient not enrolled might mean that we submitted the wrong patient to the wrong insurance, indicating an overlay potentially, and so forth. And finally, I want to discuss billing errors, meaning sometimes patients will call the hospitals or providers directly and say, hey, I got an EOB or I got an invoice for a bill, but I never saw you for a broken arm. I was never pregnant with children. Whatever the case is, the patient views these as financial errors, billing errors. But what you and I both know is that the billing errors come directly from clinical data that's in that patient's record. So we can use that tip off from the patient that, hey, there's overlay data inside of that record, which I know most of the providers do that today. But what we don't do is catalog those patient notifications of errors and then study them systemically to see what problems might be occurring on a routine basis. Is it a specific name type? Is it a specific location or types of procedure that's given us problems? That information is good to know in the large so we can prevent errors from happening in the future. So it's been a long talk, but my conclusions are the following. We have many ways to detect errors, and if we use them together, a compound error, say in demographics and in billing, or billing and say clinical inconsistencies, when we get multiple hits on the same encounter for the same patient, then we know that we potentially have problems. We're not even addressing in this hour-long discussion how to find the correct patient with the wrong encounter data. That's a topic for another day. But yes, there's a solution for that as well. But when we trigger on multiple data types, we have a much higher certainty of an overlay data error. There's a few techniques we can use to prevent these errors from occurring. One is we should implement policies to help limit who can update medical records, not just anyone at the front desk, but maybe specially trained staff that should be aware and alert for overlays. We could also update our newborn naming conventions to make baby names that are more unique, like Barbara's son instead of baby boy. And as I mentioned earlier, we should capture all the data changes so we can help unwind merges as well as detect duplicate data more effectively. And my last suggestion, I've talked about this a little bit in different points, but modern search tools are available and can augment the workflow to help better find patients. If we can find the right patient, we won't have duplicates or overlays. And I think it's time to consider specialized search tools because they do a better job than EHRs. Until EHRs come to terms with modern Google-like search, this is a function we really need. Let the system do the work. Don't rely on the cleverness of front-end staff to find patients that are hard to find. And I'll close out with this, a couple things. First, I have an infographic that's available that cleanly summarizes some of these overlay concepts, how these errors occur, and you can follow the QR code to get more information on those. Happy to send that out to you. And I'll mention that because we need more data, more study, is I will offer to do an analysis of up to 2 audience members, including the virtual audience, analysis on their data to look for overlays within their clinical data, to help get more scientific information, to help better quantify the extent of this data errors, and to give a report to the provider of the data about what possible errors they face in their EHR. So feel free to reach out to me in my contact section if you have any interest in that at all. I'm more than happy to work with you, either be unnamed or a named source in my studies. And lastly, thank you from the bottom of my heart. This is a topic near and dear to me, and I'm so glad you had an interest in it. My contacts are here. Connect with me on LinkedIn by this QR code. Follow my research, and maybe we can work together on solving this very difficult problem. And let's stay in touch.